Hello, my name is Abigail Aguilar and I will be presenting my scholarly project. The title of my project is Assess Prediabetes Risk by the Implementation of a Standardized Risk Tool. So my committee members include my chair, Ashton Lindsay, my second reader, Jennifer Brunworth, and the site member, Holly Vaughn. So kind of just a brief overview of the abstract. The purpose is to improve diabetes screening and risk through the implementation of a standardized screening tool. So the PICO question that was created to be able to guide this project was in non-pregnant adult patients who have a body mass index of greater than 25. Does the implementation of the diabetes risk tool as compared to no screening tool improve screening and assess risk for prediabetes? So to the right here we have the diabetes risk tool through the American Diabetes Association, which permission was obtained to use this. Consists of 7 questions. The diabetes risk tool consists of 7 questions, which include gender, how old you are, the age, whether you have diagnosed with gestational diabetes or not, family history of diabetes, history of high blood pressure, physically active, and the weight category. So with these different risk factors, you have a score, and if you're scored at 5 or higher, you are considered to be at risk, which we'll go into further detail. The background is type 2 diabetes is an increasing at an estimated 95% of 30 million people in the United States. This again can be related to the lack of screening tool that can lead to undiagnosed diabetes, which can lead to further complications. So again, being able to identify the risk factors that could contribute to diabetes. So methods, it is a quality improvement quantitative study implementation through the implementation of the diabetes risk tool. And results, we did use 2 different tests, the Mann-Whitney and the Z-test. One of them, Z-test, was considered to be significant and the Mann-Whitney was not, and again we'll go into further detail about these. And the conclusion, it was significant results were able to use to support the implementation of the standardized screening tool and support the PICO question as well. Okay, so now we're going to talk about just kind of an introduction to the project. The project will be implemented in a federal qualified health center, and this health center does not have a screening tool in place. So again, there's a lack of standardized screening tool. There's no protocol that is set in place. They do follow the standard of care, and so being able to have the purpose, which is and the aim at improving screening for diabetes and assessing the patient's risk for diabetes by the implementation of this tool is important, and be able to present this to the facility as well, since they do not have a screening tool in place. So the use of the DRT tool that we did discuss earlier, and with all those different risk factors, this will actually benefit the facility to be able to identify patients who are at risk and be able to diagnose them if diagnostic testing is prompted. There's undiagnosed diabetes can lead to increased cost of the disease, lead to complication, and increase with risk factors that are in place. Again, this goes back to the DRT and the different risk factors that it does assess and ask questions about. So those have all been linked to the increase with somebody who does have diabetes. And in regards to the increased cost of diabetes, there was an article by Zuel et al. 2014, which discussed that an estimated $124,000 could be saved related to lifetime medical costs for an average person aged 40 or greater with type 2 diabetes when certain interventions were applied. And it further kind of goes into detail discussing how damage can occur in that the microvascular and macrovascular damage can occur in the early stage as early onset in prediabetes. So when we talk about prediabetes, we're talking about hemoglobin A1C of 5.6 or greater, which has been defined through the American Diabetes Association. So that is where our value will start at with the diagnosis of diabetes. So again, increased cost and burden to the patients in the healthcare, importance of disease management. So being able to educate patients on their disease, if they have it, they are diagnosed, managing it, what the next steps will be, and be able to prevent this disease from progressing, whether it's from early onset, being at risk for prediabetes, being pre-diabetic or type 2 diabetic, being able to prevent it from progressing and getting worse, which at the end can lead to further complication and increased costs, and etc. So also focuses on improving population health and health equity. With this facility, where the project is taking place as a federally qualified health center, so again, These patients are at risk already of having poor outcomes due to lack of availability of resources, healthcare, and even income. So we want to be able to focus on improving their health status, provide high quality of delivery of care, regardless if they can have the income means to be able to pay for it or not. And then also, again, the focus on the underserved patients. So really, this clinic would benefit a lot for this project to be able to at least help them in this stage of the diabetes and improve outcomes for them. So some aims are implement the standardized screening tool, improve diabetes screening and risk, which is part of the PICO question and kind of how we formulated this. And based off of the PICO question that we discussed earlier, there were 2 different outcomes that were created to be able to be measured through running certain tests that we'll discuss later as well. The first outcome measure entails whether or not a hemoglobin A1C was ordered when a score of greater than 5 was noted. And then the second outcome measured the value of each hemoglobin A1C that was ordered. So both of these measures we'll discuss later in detail and kind of what results we created when we review the data that was done pre and post implementation of the diabetes risk tool. And also another aim, as we've been discussing from the beginning, is being able to serve the underserved population, improve the health equity and population health. So these patients are at risk, so being able to support them in that manner is very important. And also support for the project and the facility itself. They would benefit from this as well. You know, kind of a little bit more detail about the facility. There are several resources that are available and payment plans in place to be able to help patients whenever they don't have the means to have care provided. So the federally qualified health center is abundant and the outcome is interchangeable to be able to make a difference in the patient's health status. So they were very supportive of the project and be able to make a difference in the patient's life. So now we're going to go into detail and just briefly discuss the review of literature. So there were several different articles that were researched, but 10 of them were analyzed for this. So relevant themes that were noted through these were 3 different ones: diabetes risk factors, screening tools, and diabetes identification and management. So diabetes risk factors, some common risk factors included age, weight, body mass index greater than or equal to 25, which could be considered overweight, history of gestational diabetes in females, and Latino ethnicity groups, and a family history of diabetes. So as you can kind of relate and review these risk factors, these were risk factors that were also used and have been used for the guidance and creation of the diabetes risk tool that was developed by the Diabetes Association. So it's good to be able to have research that also goes and focuses on these risk factors as well. Another theme was screening tools. So all of them, the focus was on diabetes screening and being able to detect those patients who are at risk. Specifically, the diabetes risk tool, which was developed by the American Diabetes Association, that was the one that was used, and it was supported by many of the research articles. Again, it focused on 7 questions that we did review based on risk factors that were noted. So it was used in various studies with great reliability and validity results. The last theme that noted was prediabetes identification and management. So all the articles stressed the importance of prediabetes identification. Disease progression and diagnostic testing support was also identified. So being able to have these different factors underneath there is also important because, you know, the project again is aimed at being able to improve screening for diabetes and assess the risk. And, you know, with the testing that was done, if the patient agreed to have it done or not, we were able to detect if there was a disease or the diagnosis of prediabetes or type 2 diabetes and be able to prevent that disease progression with proper education and whatnot. Obviously, this research or this project does not go into detail about everything that was done afterwards, but at least it's a start to be able to point the patient in the right direction. And then briefly talk about the literature critique. Some strains were that they all met regulations and proper IRB approval. There were large sample sizes, about half of the studies from 160 to 700, which was very, very good to support the reliability and validity of these studies and consistency with similar risk factors that we discussed. On the other hand, with the weaknesses, the other half did have small sample sizes, about less than 100. So again, that could become a factor when we talk about the reliability of these studies. And then the cross-sectional versus longitudinal studies. So kind of the time frame of these studies was another weakness. So gaps was 3 of them that were noted were the importance of standardized screening tools. Again, a lot of them talked about the importance of diabetes screening, but it didn't go into detail about having a standardized screening tool. So this project that we're going to be that I'm focusing on with my project focuses more on the standardized screening tool for diabetes versus just the importance of diabetes screening. Another gap is follow-up care after diagnosis was made. A few articles discuss following steps after that, and then discussion of burden of costs. Again, they didn't really go into detail on that. Limitations, again, we kind of talked about the sample size, geographic location, and the availability of diabetes screening programs in place. So lastly, I'm going to talk about the theoretical framework. So the one that I used was Kurt Lewin's field theory. So this has been proven to be efficient in developing a change in different clinical settings by Batras et al. 2016 and Lewin, 1947. So Lewin provides the field theory that focuses on a group's behavior, that organizational structure, policies, and market can influence and management and personal characteristics. So he further kind of defines it into 3 different steps, which I will be going into detail on. So, and how I kind of use this to guide my project. So unfreezing stage is where the problem was discussed. The change involved implementation of the diabetes risk tool and discussing how this could directly and indirectly affect the quality measures in place that stem from diabetes. So the clinic has different quality measures in place, and one of them being diabetes. These quality measures are important because if they are met, the facility can benefit from that, and they receive grants, which is further used to help with the patient's costs, and also the facility to be able to provide more patient care, with whether it's purchasing equipment or whatnot. So again, kind of reviewing this in the unfreezing stage, the benefit to practice improvement of those measures was noted here. In the moving stage, the change is implemented, and learning, action, research, and continual modifications are made. So this is where the actual tool is implemented. In the refreezing stage, the change becomes supported by the current policies, practices, culture, and continuation of change. So again, the data was collected, it was reviewed, and discussed the need for the standardized screening tool to be able to see if this would be something that could be implemented into practice. Do policies need to be changed to be able to have this in the assessment, and then also kind of further discussion of the electronic medical records or the charting system. Is this something that could be done in that means? So it was really a really easy process with the steps to be able to implement the change and kind of work with everybody involved. So now we're going to talk about methods. So again, the purpose of the DMP is to improve screening and assess a patient's risk for diabetes through the implementation of the diabetes risk tool, which we have discussed already. Again, there was no current guidelines that was set in place for the diabetes, and also to address the follow-up steps for the continuation of care. So the focus was on providing that support, implementing a screening tool that would further aid the detection of diabetes. So being able to have the early identification of diabetes was a big goal, not only at the health center level, but also the national level down the road. So increasing this awareness through the screening and potentially early testing was an important goal to promote the population health. The scholarly project was processed and implemented using the diabetes risk tool, which we already discussed, as a standardized screening tool, not just diabetes screening tool. It consists of questions that are aimed at detecting risk factors for diabetes that may exist. So the tool scored patients greater than 5 based on risk factors noted. If it was greater than 5, they were advised to have further testing performed. In this case, the hemoglobin A1C was advised to get done. So they weren't forced to have it done. If they agreed to have it done, they did proceed to have it done. So the data was collected via retrospective chart review and a pre and post design. So it was collected over about 5 months from November 1st, 2022 to March 1st, 2023. The data was reviewed during the pre-implementation process by applying the inclusion and exclusion criteria to those that were applicable, which we'll discuss here in a little bit, and the same was completed with the implementation of the data collection. Inclusion and exclusion criteria were applied to ensure that the adequacy and quality of the data collection and decrease any false results. Again, briefly kind of summarizing the DRT, which consisted of age, gender, personal history of gestational diabetes, family history of diabetes, personal history of high blood pressure, physically active, and BMI. So kind of briefly discussing the sample that was used. Data collection consists of minimum necessary data in order to meet the variables indicated without any patient identifiers, and this was used to the assistance of IT there at the facility. There was an average of 154 participants, which were included in both the pre and the post-implementation process. About half, 77 pre and 77 post, of the electronic medical records were reviewed to meet the inclusion criteria. So this includes the patient is 18 years of age and older, the patient is non-pregnant, the patient has visited from November 1st, 2022 to March 1st, 2023 for data collection. The patient does not have a diagnosis of diabetes, and the patient has not had a hemoglobin A1C performed, and their body BMI is greater than 24. The exclusion criteria is if the patient is less than 18 years of age, the patient will be excluded and no data will be retrieved. If the patient is pregnant, they were automatically excluded as well. If there is a diagnosis of prediabetes type 1 or type 2, the patient will be excluded. And then if the patient has a hemoglobin A1C, they will be excluded as well. So the results of the Quality Improvement Project were analyzed and used to support further the outcomes noted as we discussed, which was whether or not a hemoglobin A1C was ordered, and then also the score. So which was the second outcome was the value of the score. So these two measures were further created to support the PICO question. Again, in non-pregnant adult patients who have a body mass index of greater than 25, does the implementation of the DRT as compared to no screening to improve screening and assess risk for diabetes. So these two tests, the Z test, difference of two proportions, and the Mann-Whitney U was analyzed. So the Mann-Whitney was noted to be the most accurate and appropriate, because initially there was also going to be the sample T test, but that was not noted to be appropriate. So there were 71 subjects. There were 71 subjects who were analyzed pre-implementation per criteria, and only 31 subjects were educated about diabetes risk. On the other hand, there were 86 subjects analyzed post-implementation of the DRT, and 100% of them were educated and informed about the risk. So this compared the average value of the hemoglobin A1C, whether it was less than or greater than 5.7. Per the ADA, the cutoff is 5.7 as defined as pre-diabetes. This is why the value was chosen to support the early diagnosis of diabetes. So about 34-44% of patients were educated, and hemoglobin A1C values were reported to be pre-diabetic. So now we're going to talk about the results here. Go into a little bit more detail about it. So the Z test was analyzed, and the results were appropriate and sufficient to provide support to continue this test. So this test was used to differentiate between two proportions related to whether hemoglobin A1C was ordered pre and post implementation of the DRT. So upon the analysis of the DRT, it was noted to be statistically significant as evidence of more hemoglobin A1C testing that was ordered post-implementation compared to pre-implementation. As you can see, according to Z 6.3668 and a P of 0.000. This did demonstrate the effectiveness of the DRT and provides patients with diabetes education based on the risk scores. So, out of 157 subjects that were assessed, the pre-implementation consisted of 71 and the post was 86. So it was noted to be statistically significant, so further support that outcome created from the PICO question. So the hemoglobin was ordered when a patient was considered at risk, as we discussed, if they scored more significant than 5. This test was practical and demonstrating a positive ratio and further supporting the PICO question. So the outcome was proven to be met as indicated by the analyzed data and noted to be significant. So 71 subjects were analyzed as discussed, and only 31 were educated. So as you can see in this graph over here, only 31 were educated on diabetes. But when compared to the post-implementation, 86 subjects were analyzed and all of them were educated. So the post-implementation involved the implementation of the DRT. As you can see in this pre-process, fewer patients were educated compared to the post-process. So that's also another positive result that we got from this test. So now we're going to go into the second outcome that was measured upon evaluating the Mann-Whitney. The significance was P 0.583, more significant than 0.05. The results of comparison of the hemoglobin A1C value pre and post of the risk were not noted to be significant as noted. However, also the power analysis was ran and evaluated, which is a test ability to demonstrate a difference if one does exist. This power was noted to be 0.0841, which is considered to be very low in strength. However, though the test was not reported to be statistically significant upon reviewing the mean of the hemoglobin A1C pre and post-implementation, the mean of pre was 6.039 and post-implementation mean was 5.973. This further supported early detection of prediabetes in patients who were considered high risk. So both of these numbers were greater than 5.7, greater than 5.6, 5.7, which gave us a diagnosis of prediabetes. So as you can see, the mean of both of those, pre and post, was at that pre-diabetic stage already. So again, supporting the importance of diabetes screening and assessing risk, because these patients are in the pre-diabetic stage and they probably didn't know about it if they weren't told about it, and being able to prompt to have further intervention, further education is key here. Let me go into... Okay, so now we're going to go into discussion and limitations. So the results were statistically significant to support the PICO measures in place. Again, only the Z test was statistically significant, but the Mann-Whitney was not. However, it did have other type of information that did provide, such as the mean of the hemoglobin A1C, which is noted to be significant in providing support for the early diagnosis of prediabetes. So it supported the use of the standardized screening tool and improved assessing diabetes screening and risk, which all supported the PICO question. Further supports other studies completed to improve diabetes screening in at-risk patients, as we discussed earlier. Some of those in the literature review, those studies were done in wellness programs, into offices, and family practice settings. Some strengths it implemented where patients are at risk of poor outcomes, so we were able to help patients out and give them a diagnosis, where on the other hand they might have had a poor outcome. It helped underserved patients, indicating closer evaluation of health status. Available resources for patient population were available if they needed it for further management. And then early management of the diabetes, which would help prevent disease progression and help decrease the cost to them. So some limitations, really little to no limitations in the project, was on time with meeting dates to complete. Probably the biggest thing was the bigger sample size and time frame as well. Post-implementation Insight project was organized, smooth, on time. There was effective communication with facilitators in place, and ensured data was collected and retrieved. SIR interpretation, positive and expected results due to no baseline screening tool in place. Dominant risk factors were evaluated prior to project implementation to assess needs. Desired outcomes were expected. So, for instance, the data was proven effective in supporting the implementation of a standardized screening tool, and which supported the PICO question. Several studies were analyzed, and recommendations per the United States Preventative Service Task Force were also used to create the population of focus. This further was used to create the inclusion and exclusion criteria. So it was compared to the guidance or recommendations of this task force. So implications for practice. So really improved screening for diabetes was the biggest thing, and what the main goal was of the project: improve population health and health equity, being able to access grants through being able to meet measures in place at the clinic, meeting care guidelines and measures in place. Again, that all will focus on the population health and health equity, being able to provide patients with resources when there was none available, and those patients who are high risk and have a lack of resources. Improved delivery of care, improve assessment of the social determinants of health. Again, these are really a lot of the focuses of the federally qualified health centers, so it really went hand in hand with their goals in place. Help to improve any gaps in care as an advanced practice registered nurse. Again, being able to work in the future in a rural health clinic where maybe an MD or DO is not available as an APRN, being able to deliver that care and close those gaps is also an implication for practice. Demonstrate efficacy of standardized screening tools. It supports future research for ongoing screening tools and results. Improve quality and safety related to delivery of care. Improve research and support for diabetes screening and early management. Support the use of evidence-based practice as well. The deliverance of care must be efficient, effective, safe, and focus on population health and improving health equity to provide quality health care. So overview, really kind of discussing the DNP essentials. We were able to meet all of the DNP essentials through this project that was created, and the different essentials, that have been summarized through our classes, being able to work through each class and creating the project from chapter 1 all the way up to the final. Every every of those essentials was met through the research, through study evaluation, data analysis, and the implementation of the project. Significant results were noted and proven to support the implementation of the diabetes screening in a primary care setting. So it improved screening, it assessed diabetes risk, and it helped support early treatment. Improved local and federal programs in place, and improved delivery of care in primary care settings towards the importance of screening. So really the whole DNP project and the program was very efficient and was great. It really opened my mind to the importance of APRNs in healthcare and be able to close those gaps in healthcare and hopefully work towards being able to expand our scope of practice here in Missouri, which is where I reside. So this project really opened up my mind and thinking of being able to be there as a primary care provider and patients who are underserved and maybe who are at increased risk of having poor outcomes, or maybe they may not be have the ability to be seen by a medical an MD or a DO, but being able to be there as an APRN and provide that collaborative practice approach with my collaborator and help the patient towards a better tomorrow, improve their health outcome, and really the big focus, population health and health equity. Again, I know I keep repeating myself, but those two are very, very important areas that we should always focus with every single patient that comes in the door, regardless if they have the resources to be able to take care of themselves or not. And I will have some time for some questions as well, if there are any. And here's just a list of my references for the whole project. Thank you guys again for everything. And I am very pleased with the results of this project and the positive results that it had impact on the clinic. Thank you again.